What's up, Ninja Nerds? In this video today, we're going to be talking about nephrolithiasis. Before we get started going over nephrolithiasis and the depths of it, I want you guys to please, if you guys like this video, it makes sense, it helps you, please support us. And one of the best ways that you guys can do that is by hitting that like button, commenting down in the comment section, and please subscribe. It really goes a long way in helping us to continue to keep putting out free videos for you guys' enjoyment. Also, I really urge you guys, if you guys want some great notes, some illustrations that I think are crucial to understanding these topics and following along with me, go down in the description box below to take you to our website, all right? But let's get into talking about nephrolithiasis. The basic concept of nephrolithiasis is a three-pronged system, and I think that this is a nice way of outlining it because we're gonna repeat this basic foundation non-stop. So the pathophysiology behind nephrolithiasis will help us to explain the types of nephrolithiasis. It'll help us to describe the diagnostics behind nephrolithiasis, and it'll help us to describe the treatment behind nephrolithiasis. So get this foundation down and you will be set. All right, so how does this all work? Well, when we want to form these, we don't want to, but unfortunately, we form these crystals, these nasty little stones that can form anywhere between like the renal pelvis, maybe in the calyces, maybe in the ureter, maybe even down near like where the bladder and the ureter joins, what we call the UVJ, the ureterovesicular junction, very, very common area for stones to get stuck. We have to understand the three reasons why we form these. So I want you to write down in arrows here. One is you're going to have a down arrow, you're going to have a down arrow, and you're going to have an up arrow. All right, here we go. We're going to explain each one of these. So for the down arrows, I want you to remember that one of the reasons why we form these stones is you have less urinary solvent. You're like, what the heck does that mean? Well, when you have less urinary solvent, you have less water inside of your actual urinary structures. When there's less urinary solvent, the problem behind that is that really increases like the supersaturation like of these substances in the urine. And then when you have supersaturation, the problem is that you make solutes inside of the urine precipitate. So you do what's called solute precipitation. And when the solutes precipitate out of solution, this leads to the subsequent crystal formation. So a decrease in urinary solvent induces supersaturation of solutes. The solutes precipitate and they increase the formation of these nasty crystals known as nephrolithiasis. So that's the problem, is you have a decrease in solvent, you supersaturate the solution, you precipitate your solutes, and you end up with crystal formation. This nasty little thing that you see here, this stone that's going to be causing problems for us. All right, that's one mechanism. When we talk about urinary solvents, a decrease in urinary solvent, there's one way that you guys can remember this one. And it's probably, thank goodness, the most easy one to remember. This one is when you're going to be dehydrated. So this would be a very common etiology for patients. So when patients are dehydrated, it definitely increases the risk of solute supersaturation, precipitation, and crystal formation. All right, good. What's the next down arrow? The next one is we have a decrease in things that are supposed to inhibit stone formation. So we have less stone inhibitors, less stone inhibitors. This is really, really crucial. So whenever you have less stone inhibitors, what happens is these basically increase solute precipitation. So when you don't have these, they end up stimulating very heavily solute precipitation. They're supposed to inhibit solute precipitation. But if you don't have them, you will precipitate solutes and cause crystal formation, and stones will get stuck within the urinary system. What are things that basically are supposed to inhibit stone formation, but if we don't have them, or there's not them being present, they can cause this supersaturation effect? Well, one of them is urine pH. So urine pH is a very heavily involved thing within stone inhibition. So normally, in certain pHs, depending upon the urinary pH, so what we'll do is we'll actually kind of like a little bifurcation here. We're gonna have like a little bifurcation. One thing is whenever you have very low urinary pHs, it really increases the risk. So you have high urine pH and low urine pH, and we'll get into this in a little bit more detail. But you have a low urine pH, and then you have a high urine pH. At low urine pHs, it increases the formation of particular stones, and at high urine pHs, it increases the formation of particular stones. And that's why this is a problem. So the question then comes, what kind of stones? We'll get into these into detail later, so don't get bogged down just yet. But the ones at low urine pH is going to be things like uric acid stones and what's called cystine stones. Whereas at high urine pHs, you form something called calcium phosphate stones, and another beautiful one called struvite stones. Also make these things called staghorn calculi. But that's one concept. So we know if a patient's dehydrated, they're at high risk for stones. If they have high urine pH, they're at risk for struvite and calcium phosphate stones. If they have low urine pH, they're at high risk for uric acid and cystine stones. All right, cool. The next thing here is there's a molecule called citrate. And citrate is really helpful in being able to bind with calcium. So whenever our body has less citrate within the urine, so there's less what's called urinary citrate. Let's say this, less urinary, because I really want us to be very particular. When there's less urinary citrate, citrate is supposed to bind with calcium. And if it doesn't bind with calcium, guess who the calcium loves to bind with? Calcium oxalate. And so the problem with having low urinary citrate is you don't have the ability to inhibit calcium oxalate crystals. And then you increase the risk of what's called calcium oxalate stones. All right. So we know less solvent increases stone formation. So if you're dehydrated, you have a high risk of stones. We know if you have less kind of stone inhibitors, in other words, high urine pH, low urine pH, it can potentially increase the risk of specific types of stones. And we know if you have less citrate within the urine, that also can increase the risk of calcium not binding with citrate anymore, instead binding with oxalate and forming calcium oxalate stones. All right, we come over here to this next puppy right here. It's the same concept here, where now you have an increase in urinary solutes. Urinary solutes. And whenever you increase these urinary solutes, it does the same thing. It causes the saturation of the urinary substances to really kind of increase, and it forms what's called supersaturation. That supersaturation leads to solute precipitation. And that solute precipitation, my friends, is what induces crystal formation. So you're going to notice an increase in supersaturation, an increase in solute precipitation, and an increase in subsequent crystal formation, all because you're having too many urinary solutes. All right. Now the question then arises, what's the reason for lots of urinary solutes, or what are these urinary solutes that are causing crystals to form? Well, we're going to go over these in pretty decent detail as we go along, but there's a couple of them that I want you to remember. One is if you have a lot of calcium, a lot of uric acid, a lot of cystine, and another one is a lot of oxalate. And we'll go over these in great detail. But one problem would be if you have way too much calcium, way too much uric acid, way too much oxalate, and way too much cystine. And you can kind of get an idea here of what kind of stones you would form based upon a lot of these solutes. I think it can kind of be relatively obvious here, right? So if you have lots of calcium, you increase the risk of calcium phosphate and calcium oxalate stones. If you have lots of uric acid, you increase the formation of uric acid stones. If you have lots of oxalate, you increase the formation of calcium oxalate stones. And if you have lots of cystine, you increase the formation of cystine stones. Out of all of these, probably the most significant ones are going to be oxalate. It's a really, really powerful one. So whenever you have lots of oxalate, it really increases the formation of calcium oxalate stones. So that's the things that I want you to take away from this. And the big takeaway for understanding the pathophysiology behind stone formation is the three particular concepts. Ingrain this into your brain, my friends, is that if you have less solvent, less stone inhibitors, and lots of solutes, this will increase stone formation, all right? So this is the way I want you to kind of ingrain this into your brain, because I really think that it'll help you whenever we get through all of these other kind of like specific stones, diagnostics, etc. All right, my friends, now we move into the next part here. So if we talk about the next part down here, we're going to go into, okay, we formed the stones because of too much solute, less solvent, less stone inhibitors. Once we form these stones and they get stuck somewhere within the urinary tract, and they can get stuck really, I told you, anywhere. So if I were to highlight, imagine it got stuck here, maybe in like one of like the calyces, or maybe it got stuck here in the pelvis, or it got stuck here in the ureter, or it got stuck right at the point where the ureter joins with the bladder called the UVJ. It gets stuck, it causes a lot of effects, right? One of those is it can cause ureter mucosal irritation. If you rip and shred that ureter mucosa, what do you think is going to happen, my friends? Well, you can erode through the tissue and lead to hematuria. Because then if I erode through the tissue wall and I expose some of the underlying capillary beds, guess what? There becomes an opportunity for blood to flow right into the lumen of the ureter. Okay, because what we're doing is we're zooming in on like a ureter. We're really zooming in on this particular area right here. Another thing is, when you erode or injure the tissue, and I really want to be particular here, let's say that the area that I'm actually zooming in on in this part of the ureter for this next step here is a very specific point. So it's right where the bladder and the ureter kind of combine. So right here, let's say that there is a stone right here. We call this the UVJ. I'm going to abbreviate this, UVJ, the ureterovesicular junction. And let's say that at this area, you start agitating and eroding the mucosal tissue. When that happens, there's very sensitive areas in that area. Like right here, it's very, very sensitive. And what it does is, it produces urinary tract symptoms, like infection-like symptoms, which is kind of odd, right? So it can produce things like frequency of urination. It can produce urgency, where you got to go now. And it can even produce like some type of pain with urination. And so this is a very interesting feature where you can have UTI-like symptoms, but it's most commonly going to be when it's near the UVJ, right where it kind of combines or gets close to the area of the bladder. There's a sensitive area there called the trigone, and it's very sensitive to irritation. It can cause UTI-like symptoms. All right, so that's one effect. The second thing is if this thing gets stuck somewhere within the flow of urine, right? Imagine here it gets stuck in the ureter. So if you got a stone, it's pretty big. Generally, like when you start getting stones, and we're zooming in on the ureter again here, let's say that this stone starts kind of impeding like, greater than or equal to 10 millimeters. Usually when they're like greater than 10 millimeters, it's really hard for them to pass through the ureter. And so if they get stuck here in the ureter, they really start kind of stretching and agitating that ureter. And when you stretch, there's little stretch receptors present within the walls of the ureter. And so what you're going to do is you're going to stimulate a stretch stimulus from this stone being too big to be able to pass. When it causes this stretch stimulus, it stimulates nerve fibers that create a reflexive kind of contraction, because it's kind of a natural response. You stretch, it should kind of cause like a ureteral kind of peristaltic reaction. So the natural effect here is you should see what's called a contraction, like a peristaltic contraction. Problem is that this poor ureter contracts down on the stone. And when you contract down on the stone, guess what happens, my friends? It produces an intense pain. So what it'll do is it'll cause kind of like a flank pain. And this pain can have the ability to radiate. And so I'm going to put it like this. It can radiate to the groin. But it's going to be like a background pain. So that's going to be from it stretching. But then when it spasms, it produces like a really nasty kind of amplified pain. So you're going to have this flank pain that can radiate to the area of the groin, but it also can have these intermittent increased bursts of pain. And that's due to the spasm. That's due to that contraction of the ureter from the stretching of that kind of stone within the ureter, stretching out the ureter, it's going to produce this kind of burst of pain. We call this renal colic, because it's kind of like you have this background pain, but you have these intermittent bursts of pain. They come in kind of waves because it's like the spasming of the ureter, like and that's called renal colic. This pain can be so intense that sometimes, if the pain is so intense, it can cause stimulation of afferent fibers of like your parasympathetic nervous system to go to the actual medulla. You know, there's an area of the medulla called the emetic center. And whenever pain is just unsurmounting, especially from visceral pain, it can cause the activation of this nerve, with these nerves, the vagus nerve, to go to the emetic center of the medulla and stimulate vomiting. And so another thing that can be very, very common with these patients is that they can also have vomiting secondary to the intense pain. So watch for that as well. All right. So very common features that most patients will present with is this, that flank pain. They may even have it radiating to the groin. The flank pain can even be sometimes so bad it produces something called CVA tenderness, where you go and tap on the area of the kidney where it would be, and it causes this intense kind of like guarding and pain. And it can cause these intermittent increase in bursts of pain due to the ureteral spasm from stretching, and it can be associated with vomiting. And you also may see hematuria with this, microscopic. The only time you see the UTI symptoms is if it's near the UVJ. All right. Here's the scary complications. Okay, so we got ureteral mucosal irritation. We got kind of like stone stretching and spasm as this effect here. This is the scary one. This one is you produce a backflow pressure. And this backflow pressure can precipitate a really nasty thing. So in this one, you have a stone and it's causing a lot of backflow pressure. All right, so here's the stone. It's blocking up the flow of urine. Urine, then, which is supposed to go down this way, is not, starts backing up into the kidney. When it backs up into the kidney starts becoming bigger and parts of the kidney start dilating and becoming very large. And we call this hydronephrosis. So you may see kind of some enlargement of the kidneys filled with a lot of fluid. It's kind of like waterlogged. In this case, it's actually urine, but it's called hydronephrosis. The problem is when you back up all of this fluid, it kind of starts backing up into the little small structural and functional units of the kidney, which is called the nephron. So imagine here, the fluid starts backing up into these little nephrons. What happens to the pressure inside of this capsule? The pressure goes up. So you end up with an increase in what's called the capsular hydrostatic pressure. And when you increase the capsular hydrostatic pressure, guess what it does to the pressure that's supposed to be pushing things out? It's the GFR. It's going to reduce the glomerular filtration rate. If you reduce the glomerular filtration rate, you reduce the actual excretion of particular substances from the body. What would that look like? Well, maybe particular solutes that you're supposed to be filtering, you are not. And so you end up with an increase in things like the BUN, you end up with increases in things like the creatinine, or you see a decrease in the patient's urine output because they're obstructing the flow. What is this called when you have an acute rise in the BUN, an acute rise in the creatinine, and an acute decrease in the urine output? This is called an acute kidney injury. And this is something that is potentially possible with a very large stone. But to add on to this, in order to truly cause an acute kidney injury, you would really, and you need to pay attention to this, an acute kidney injury is only possible under two circumstances from a stone. One is if it's bilateral stones. So you have to have stones in both ureters to knock out your actual nephrons. The second is you only have one kidney. So either way, the point is you have to be knocking out all of the kidney structural units to truly cause an AKI. So the only way that an AKI can be precipitated is if you have one kidney or you got stones in both of the kidney ureters. That's the only way. But this is a very nasty complication. When you have something like this is kind of concerning for emergencies. So this is kind of telling me that this could be potentially an emergent nephrolithiasis. Because if I'm having dysfunctional kidneys, that means that the stone is causing real significant issues like renal failure. Okay? Really remember that one. All right, another one. This one's sad. You can see this one, and I'd say this one's relatively common, and it's usually the highest risk of emergency, is you can increase what's called urinary stasis. Now, whenever you have the stone blocking the flow, guess not only is it supposed to be urine flowing through, but it's supposed to be bacteria flowing through. And if I don't allow for the bacteria to flow through, what do you think is going to happen, my friends? The bacteria will stay in the ureter, it'll back up all the way into the kidneys, and if it backs up into the kidney, these bacteria can start causing damage, infection, injury, inflammation of the actual kidneys itself. And sometimes, here's the even worse part, these little bacteria could get into our actual systemic circulation. Imagine this bacteria getting into your systemic circulation. Now you end up with bacteremia, and if that bacteremia starts producing negative consequences, you can end up with sepsis. So the big things to watch out for here is, from the fluid backing up and the bacteria backing up, you can get something called hydronephrosis, but you can also get something called pyelonephritis. So let's write both of these down. One is that as the fluid and bacteria back up, it causes the big old kidney called hydronephrosis. But the other thing is, if this kind of bacteria that kind of backs up here and causes colonization and eventually causes infection, this can produce something called pyelonephritis. And this is scary. This is a renal infection. And the complications is, if this actually gets into the bloodstream, this sucker can produce what's called sepsis. And it's a very specific type of sepsis. To really denote it, we call it a urosepsis. And this is basically when it causes renal infection and it spreads into the actual bloodstream. So you really want to watch out for things like this as well. If you have any evidence of pyelonephritis or urosepsis, my friends, then this is concerning, because this tells me that this patient has a very high risk of potentially mortality, and this is an emergent nephrolithiasis. So you're getting the point here that AKI and pyelonephritis with potential urosepsis is very emergent scenarios. There is one more. If the patient has renal colic, we'll talk about this later, but we're supposed to treat these patients with pain medications and other therapies. If this renal colic and this vomiting is refractory, like it is literally uncontrollable, you can consider this to be an emergent nephrolithiasis, but it has to be like literally out of control, refractory to multiple medical therapies. So if you have this, and again, it is so intractable, so uncontrollable, we can consider that to be an emergent nephrolithiasis. But oftentimes, it's these two that are the more concerning ones. All right, next thing is we have to go through and say, what are the different types of stones that are forming within these actual urinary tracts? All right, my friends, so now we know the three basic principles to stone formation. It is less solvent, less stone inhibitors, particularly urinary pH and citrate, and we know which ones that are pertinent for, but we'll keep recapping it. And we know that there's lots of urinary solutes, calcium, uric acid, oxalate, and cysteine. They should make it very easy for us to go through and kind of nitpick throughout each one of these to understand stone formation, because this is critical for your exams as well as for the diagnostics portion. So big thing is, the most common stone that you're going to see is going to be your calcium containing stones. More likely calcium oxalate over calcium phosphate stones. But again, these are going to be the two most common stones. So when you see stones in generally most patient populations, it's oftentimes going to be this one or this one, okay? Now, with calcium oxalate stones, let's go back to the 3-point prong system here that we know it's decreased solvent we know it's decreased stone inhibitors, and we know that there is increase in solutes. And all of these things led to nephrolithiasis, right? Supersaturation, solute precipitation, crystal formation. So we said, and this is going to be an overarching theme for every single one of them, solvent. What would be a cause? Dehydration. So anytime a patient is dehydrated, they have a high risk of stone formation. The second one is we have less stone inhibitors. Now I said that urinary pH was particular for every one of these stones except for calcium oxalate stones. Some literature will say that calcium oxalate stones form more particularly in acidic pHs, but the true matter of it is in that most other literature says that calcium oxalate stones can form really at any pH. They're not truly pH dependent. So I wouldn't really focus on that here. What I would focus on for the less stone inhibitors is less of the citrate. And that is where we got to focus here. So just to keep these colors the same, I don't want to be OCD here, but again, dehydration, and then the big thing for this one is going to be less citrate. So that begs the question. We said that we know that less citrate means that you're going to have less of calcium binding to the citrate and more of the calcium binding to oxalate. Let's quickly talk about some reasons as to why you'll have less citrate, particularly in the urine. And guess what? It's actually very easy. The reason why is you absorb the citrate. You have an increased absorption of citrate. All right, so the real reason why this would happen is you have an increased absorption of citrate. What's the reason that you have an increased absorption of citrate? The reason we have an increased absorption of citrate is because of acidosis in the tubule. So increased citrate absorption, so therefore there is less of the citrate in the urine. The reasons for this is what's called type 2 renal tubular acidosis and a drug that can cause a similar effect to type 2 RTA. And this is called acetazolamide. All right, let me explain how this actually happens. All right, what these things do here is naturally these kind of molecules here basically inhibit the reabsorption of bicarbonate. All right, when they inhibit the reabsorption of bicarbonate, what happens is you'll notice that in the distal part of your nephrons, and the distal part of your nephrons, like towards the distal convoluted tubule, they're supposed to secrete protons. Those are intact. And because those are intact, the pH within inside of the urine is actually going to be acidic. And so because of that, what happens here is these will actually cause more protons to end up into the urine. These will cause an increase in protons to form within the urine. So this is why some textbooks will say that, oh, well, if it's technically in acidic conditions, that's calcium oxalate. Yes, but really it's the acidic urine that's causing less citrate to be present within the urine. So if there's lots of protons within the urine, what that does is that basically causes, let's say here we have citrate. We're going to represent that here in like this blue color. Here's my citrate molecules. Normally what I want is, I want the citrate to bind with calcium. But if it doesn't actually do that, because guess what's happening? In very acidic urine, these citrates do not like to stay in this area. And what they do is they get reabsorbed across the kidney tubules back into the bloodstream. So what happens to the amount of citrate present within the urine then? It decreases. So there's going to be more citrate within the blood and less citrate within inside of the urine. So here we'll put a down arrow, less citrate in the urine, more citrate in the blood. Now, because this does this, what happens is it's going to stimulate this kind of absorption here. You're going to have less citrate within the urine. And because of that having less citrate within the urine, we'll put less citrate in the urine. That means that more of the calcium is available to bind with oxalate. So now look what happens. Now you're going to have calcium oxalate binding. More of the calcium is available to bind with oxalate rather than being able to bind with citrate. And so this is the problem that we see here. Let's do this blue, kind of this red arrow here. Is that this is the problem that we see here with the less citrate. It was we end up stimulating this particular process. All right? So what I want you to think about is there's less citrate in the urine. Why is there less citrate in the urine? Because the urine's acidic. Why is the urine acidic? Because of a type 2 RTA and acetazolamide. It causes more protons to be in the urine, more citrate to be absorbed, less citrates in the urine, so more calcium can bind with oxalate rather than binding with citrate. All right, cool. The other concept we said here is that there's going to be lots of solutes. Now, I really want you to kind of make sense of this, and I don't think it's that hard to imagine. So we covered these. This will stimulate this. This will stimulate this. This is going to stimulate the stone formation. Don't make this complicated. Out of all the solutes, increased calcium, increased oxalate, increased uric acid, increased cysteine, which ones do you think are pertinent to calcium oxalate stones? Calcium and oxalate. All right. So we know that in this particular situation, we have to have lots of calcium, and we'll talk about the reasons why you'd have lots of that, or lots of oxalate. All right, so we either have lots of calcium or we have lots of oxalate. Now, I want to focus a little bit on the calcium. Why would we have a lot of calcium present within the urine? So there's lots of calcium present within the urine. Very important to remember here. Lots of oxalate present within the urine here. And if a lot of these are present, you can form a lot of these to precipitate and make these crystals. Well, one thing here is, think about reasons why calcium would be high in the blood and then filter off. Why would calcium be high in the blood? One is because PTH is high, or because you have a malignancy. So here's what I want you to think about. Increasing levels of particular hormones or molecules that increase hypercalcemia, and then if you have hypercalcemia, more calcium filters. So think about hyperparathyroidism, or think about malignancies. So PTHRP and calcitriol. Let's actually bring this one down so we have more room over here. So PTHRP, and then another one here which is called calcitriol. If you guys remember, this was particularly like hyperparathyroidism. This was in malignancies like a squamous cell carcinoma of the neck or the lungs. And this was in situations like lymphomas, or in patients who have granulomas like sarcoidosis. This can cause high levels of calcitriol. All right, what else? Another one, and this is the interesting one, is you basically have a decrease in calcium reabsorption. So there is a decrease in calcium reabsorption. You're like, what? What does that have to do with this? Well, I gotcha. All right, now normally if we come down here, let's say here's calcium. Here's calcium. Let's say it gets filtered, right? It gets filters across the glomerulus. It gets into the kidney tubules. Normally, if we want a lot of calcium here within the urine, that would increase the risk of these calcium oxalate stones binding, right? But let's say that for some reason, right, we're supposed to absorb some of these calcium molecules, so we don't have as much calcium within the urine to bind with oxalate. Well, if I were to take this, normally calcium should be naturally kind of reabsorbed a little bit. But let's say in a couple different situations here, I have a lot of sodium within my diet. I have a lot of protein within my diet. Or I'm taking a drug that's called a loop diuretic. In all of these particular situations, if I have an increase in my sodium diet, an increase in my protein diet, or if I'm taking loop diuretics, guess what these do? They are going to inhibit calcium reabsorption. If I inhibit calcium reabsorption, what then happens to the calcium? The calcium stays within the kidney tubules and gets peed out. So then what happens to the calcium inside of my actual urine? It goes up. So I end up with an increase in the calcium within the urine, and if I have an increase in calcium within the urine, it's going to be able to be available to bind with oxalate and form these calcium oxalate stones. So now what am I going to have here? A lot of calcium present within the urine. So one way that we can get a lot of calcium into the urine is if we don't reabsorb the calcium via these particular mechanisms. Another way that we can get a lot of calcium into the urine is if I filter a lot of calcium out of the blood and into the actual kidney tubules. What are diseases that cause lots of calcium to be within the blood? High PTH, high PTHRP, high calcitriol. You guys get the point there? So if there's lots of calcium available within the bloodstream because of hypercalcemia from these particular mechanisms, they will get filtered off, end up a lot within the urine, and then bind with oxalate and form a stone. Oh, All right, well, that's actually kind of interesting then. So I know that having these things inhibit calcium reabsorption, and these things increase the amount of calcium in the blood to be filtered, which gets a lot of calcium in the urine and gives me more stones. All right, cool. What about the oxalate? This one's actually very fascinating. For the oxalate, it is due to, I just want you to think about it like this, to make it easier on your life. There is less calcium. And I'll explain the two ways in which there is less calcium. And this may seem very, very odd, but less calcium within the diet. And that's why I really wanted to be very, very critical here. You're not having a lot of calcium in the diet, in the GIT. Let's actually add that in here for even more emphasis sake. All right, another reason is you have a lot of oxalate within your diet. So that would be another one, right? That's not hard to imagine. Is that it because of this, or you have a lot of oxalate in the diet? Now, let's come down here to this part here. Here is the GIT. All right, and things are naturally supposed to be moving, let's say here from the oral end to the anal end, all right? Now, this structure here, which is the black dot and the blue dot, this is calcium oxalate. In this form, it does not get absorbed. So if I were to try to absorb this molecule into the bloodstream, I won't be able to. Okay? I won't be able to. This little dot here, just imagine this actual black dot here is calcium. And this blue dot here, all these, is your free oxalate. And the free form of oxalate, guess what it can do? It can get heavily absorbed into the bloodstream of the GI, across the GIT. This can have heavy absorption. So oxalate can definitely be absorbed by itself, but when it's bound to calcium, it won't be able to be absorbed. So that begs the question, okay, what if I have very little calcium available to bind with oxalate? Then that would give me a lot of this free oxalate, which can be absorbed into the bloodstream. And if I get a lot of oxalate into the bloodstream, it can filter off out of the blood into the actual urine, bind with calcium and make these calcium oxalate stones, right? So all I need to do is have less calcium in my diet, or have calcium bind to something else, which takes calcium away. You see here, there's all these fat molecules. Calcium loves to bind with fat molecules. So if you have a situation where in your GIT you have a lot of fat molecules, that would be a problem. So that begs the question, what would be the reasons as to why we would have less calcium? One, it's very obvious. So the reason why we have a lot of oxalate absorption, so an increase in oxalate absorption, is a twofold reason. One is you have a low calcium diet. So there is a low calcium diet, or you have what's called a malabsorption syndrome. And in these two particular scenarios, this would cause you to have an increase in the oxalate absorption. All right, so poor calcium diet or a malabsorptive syndrome. You know, diseases like inflammatory bowel disease or pancreatic insufficiency or gastric bypass, they don't absorb fats very well. So if they don't absorb fats very well, guess what's going to happen? You're going to have lots of fats here within inside of your GIT. And if that happens, lots of the calcium will go over and bind with the fatty acids, leaving oxalate free to be absorbed. Or if you have less calcium within the diet, you have less calcium binding with oxalate, more of it goes into the free form and gets absorbed. If you have more oxalate within your bloodstream, then what happens is more of that oxalate will filter across the glomerulus, and because of that, if you have lots of calcium and lots of oxalate, which is present within the urine, guess what? Bingo, bongo, bang, you're gonna get a stone. And that is the whole process here. So lots of calcium getting into the urine, lots of oxalate getting into the urine. How does calcium get into the urine? Because of hypercalcemia, or you're inhibiting calcium reabsorption. How does oxalate get into the urine? You're absorbing a lot of it because of a low calcium diet or fat malabsorption. And if those situations, you get a lot of calcium oxalate, they can form stones. It can even be worse at higher amounts if there's less citrate, because citrate's supposed to bind up some of that calcium. If you don't have as much of that citrate, why would that be the case? Because of an acidic urine, type 2 RTA, acetazolamide. That will increase the stone formation. And if you're dehydrated, it even adds to the effect. All right, That was a lot, but that was the most intense one. And everything else should be easy at this point. For the calcium phosphate stones, it's that three-pronged system. It's a decrease in solvent, or a decrease in the stone inhibitors, or a increase in the solutes. And guess what? Thank goodness our life is kind of easy here, because we're just going to be repeating here. So if there's less solvent, what was the primary cause? Dehydration. And think, for the solutes, what do you think is the primary solute that I mentioned? It was calcium, it was oxalate, it was uric acid, and it was particularly the cysteine. The only one that's pertinent here is calcium. So in this particular situation, you're going to have a ton of calcium as your solute. And the last one here is going to be less stone inhibitors. What did I tell you? There was the only one that had low citrate was calcium oxalate. All the other ones were urinary pH dependent. What was the calcium phosphate? It was high pH. Remember, high pHs is for calcium phosphate and struvite stones. Low pHs is for uric acid and cysteine stones. So for this one, what would be the effect here? It would be having a urine pH that is very high. It'd be a urine pH that is very high. All right, so this is the basic concept here that I think we've gotten. Less solvent is because you're dehydrated. Less stone inhibitors because you have a high urine pH. These things will cause solute precipitation, crystal formation. High amounts of solutes available within the urine can cause solute precipitation and crystal formation. And this is the concept that I want you to obtain. All right, so now the easy one that we already knocked out was good. Now we got to get to this point, urine pH. Why is the urine pH high? Why is the urine pH high? All right, there's a weird disorder here, and it's called type 1 renal tubular acidosis. It's called type 1 renal tubular acidosis. The basic problem with this is that this distal part of the renal tubular system is supposed to secrete protons. In type 2 RTA, it was the proximal part that wasn't reabsorbing bicarb, but the distal part was intact. In type 1 RTA, the distal part is not intact. It's not excreting protons. It's supposed to push protons into the urine. So here, look at this. Look at this. You're supposed to be doing this right here. Are you doing this in type 1 RTA? No, there's no effect here. And so because of that, what's the end result? The end result here is that you have less protons present within the urine. If you have less protons present within the urine, this basically does what to the urinary pH? It causes the urine pH to go up. And that will basically increase what problem? All right, watch this. In the urine, you're supposed to have another molecule. You know you have a buffer system, you're supposed to have what's called protons, and they're supposed to bind with something called phosphates, right? And what these should form is they should form a molecule called HPO42 negative. You basically have this buffer system. So this is this buffer system. Now, in order to make this molecule, you need protons. Well, if I have less protons being present, am I going to be able to make this molecule? No. So what ends up building up as a result? Phosphates. So as a result, because of having less protons in the urine and the urine pH going up, guess what I'm going to have? A lot of free phosphate molecules. And that free phosphate can then go and combine with a lot of calcium, which is present within the urine, and make calcium phosphate stones. Ooh-wee! So again, less protons in the urine because of a type 1 RTA. You're going to have a high urine pH. Because of that, you're going to have a lot of phosphates, and you're going to increase your calcium phosphate stone formation. All right, so that is this mechanism. All right, that's the problem here. The other problem that we have to have is a lot of calcium. Well, what did I tell you was the reason we have a lot of calcium? Well, I said that it could be because you have a lot of calcium in the blood that's filtering out. So there was a lot of calcium within the blood, so hypercalcemia, that was getting filtered out of the kidney tubules. Or calcium, some of it should be reabsorbed. You aren't reabsorbing it. So then as an effect here, you increase the calcium available within the urine. And if I have more calcium present within the urine, guess what it can do? It can bind with the phosphate that's in the urine and make what? It can make calcium phosphate stones, right? So then you have to go back to the reason, which is why do I have a lot of calcium within the urine again? The two reasons were, in this particular fashion, you have a lot of calcium within the blood. What were the reasons you would have a lot of calcium within the blood? High PTH, like in hyperparathyroidism, or PTHrP in malignancies, high calcitriol in malignancies, or you would have less of the calcium reabsorption in the kidneys. And this was due to what particular factors? A high sodium diet, a high protein diet, and loop diuretics. All of these things could cause what particular problem? A decrease in the calcium reabsorption. So more of that is available where? In the urine. Okay? And so generally what should happen is this is supposed to go here, but it's not doing this because of these three factors. And if that doesn't happen, more of the calcium will stay within the urine and bind with the phosphate. The other thing is you're supposed to be able to filter this calcium out of the actual glomerulus into the actual filtrate. If I have lots of PTH, lots of PTHrP, lots of calcitriol, it makes a lot of calcium within the blood to be filtered. These are the mechanisms that will cause calcium phosphate stones. Whew, all right. Calcium oxalate done. Calcium phosphate done. This one, lots of calcium. This one, lots of calcium. This one, lots of oxalate. No problem with oxalate. This one, high urine pH. This one, not really pH dependent, but it causes low citrate. This one, low solvent. This one, low solvent. All right, let's come here to struvite stones. For struvite stones, another term that you may become familiar with throughout this process is what's called a staghorn calculi. So basically, these are nasty, nasty stones. You see this thing? This thing can take on the shape of like the renal pelvis and the calyces. So we call this sucker here, we call it a staghorn calculi. And this is a nasty stone. It can really cause a ton of problems. The question is why does this form? All right. Well, one is a decrease in solvent. The other one is a decrease in the stone inhibitors. There is no particular solute that is an increased amount that increases the risk of solute, of stone formation. So thankfully, we can get rid of that one. This is the only one where there's not a lot of the solute problem. It's the stone inhibition that there's less of, and it's the dehydration factor. So, less solvent. Again, what was the primary feature with this one? It was dehydration that was the cause here. All right. And for this one, it's less stone inhibitors. All right, here's where it gets a little crazy, right? And again, we know that if there's less solvent in situations of dehydration, this can potentially increase stone formation. And if there's less stone inhibitors, this can increase stone formation. Again, no problems with the solute. Question then arises, what is causing this low stone inhibition? Well, I told you it was urine pH. What was the two urine pHs that were high? Struvite and calcium phosphate. So this one is you'd have to have a high urine pH. For calcium phosphate, it was because of type 1 RTA. For this patient who has the struvite stone, their reason is because of bacteria. You got this bacteria, you see these here? You know what kind of bacteria these are? You got a bunch of them. So here, we'll kind of write these down here. You can have one called Proteus, one called Pseudomonas, and another one called Klebsiella. Klebsiella. These bacteria produce a very interesting type of enzyme. You see this blue enzyme here? They produce this blue enzyme. I'm going to write it down here. It's called urease. So they produce all these like blue kind of like enzymes. And this blue enzyme here, my friend, is called urease. So we'll kind of have these here and these all here. This is called urease. Now, urease is a very interesting enzyme. And what it does is it takes a molecule called urea and converts it into something called ammonia. So it's going to take something called urea, which is very, very concentrated within our urine, thankfully, right? And it's going to convert this into ammonia. Ammonia does what to the actual pH? Well, this is a base. What do bases do to your pH? They drop the pH. When they drop the pH, right? So they're going to drop the pH. They're going to they're going to cause an increase in the pH. I apologize. They're going to increase the pH because they're a base. What is that going to do to the actual stone formation? Well, what it does is it increases a couple different things to precipitate and bind with one another. One is you take magnesium and phosphate and guess who? Ammonia. And they precipitate and they bind with one another. And when they bind with one another, guess what they end up kind of fusing and making? They make these big honkin' staghorn calculi, which get stuck within the renal pelvis and calyce areas. And this is where you get this problem. So when I say struvite stones, I want you to think again, the big problem here is that the urine pH is high. Why? Because of the urease producing bacteria. All right, that's that one. So we got low citrate for the less stone inhibitors. We got a high urine pH due to type 1 RTA. We got a high urine pH due to urease producing bacteria. All of them are seen in dehydration. These two also seen in high amounts of calcium. This one seen in high amounts of oxalate. Uric acid stones. These things, again, it's a three-pronged system. Less solvent, high amount of solutes, and less stone inhibitors. This is going to become ingrained in your brain forever, I hope. So there's less solvent. What can we see this in? Dehydration. The other thing is that you have less stone inhibitors. What is the cause for the less stone inhibitors? All right. Well, in this particular situation, we know it's dehydration, and we know that this can stimulate the solute precipitation. We know in this one, it can also stimulate solute precipitation. But what's the cause? Well, I said low citrate and urine pH changes. We already got the two high urine pHs, so what's this one? A low urine pH. So in this one, the problem is you have a very low urine pH. So that begs the question, what would be the reason as to why you would have this low urine pH? Well, one is because if you guys remember, it was that proximal system is intact. So the proximal system is damaged, but the distal acidification systems are no longer intact. So what's that called? Type 2 RTA. So you can see this in a type 2 renal tubular acidosis. Oh, geez, not a rat, a renal tubular acidosis. The second one is you're losing bicarb in the poo. You know there's a nasty disease called diarrhea. And when you're dumping all that bicarb out into the poo, what it does is you lose bicarb in your bloodstream. And when you lose bicarb in your bloodstream, what that does is that causes the pH with inside of the blood to become very acidic. And under acidic conditions, your body is supposed to stimulate proton loss. So it's supposed to be able to stimulate proton loss because if I lose protons from my kidneys, hopefully I'll be able to bring the pH back up. So that's the goal, is I want to stimulate a lot of protons to be lost within the urine. So my goal is to induce proton loss into the urine. And how do I do this? One is because of type 2 RTA or because of diarrhea. And this causes a lot of proton loss. And if you have a lot of proton loss, what does that do to the pH? It causes the pH to drop within inside of the urine. And that will then allow for an increase in uric acid stone formation. Uric acid stones to form. So what we have been able to elude from this here is that whenever you have a low urine pH, it's due to type 2 RTA or due to diarrhea. What happens is you induce a lot of proton loss. That will cause the pH to go down, and that will increase the formation of uric acid stones. So increase the proton loss, I'm going to decrease the pH, and I'm going to increase the uric acid stone formation. Okay. That's one particular mechanism. The other one here is we have to come to the solutes. We got to have a lot of solutes, particularly within the urine. So if we have a lot of solutes, what are the particular solute that I told you that you have to be thinking about? The particular solute that you have to remember here is going to be, well, it's super easy, thank goodness, uric acid. So you're going to have a lot of uric acid, but the question is why is there a lot of uric acid within the blood? Well, the reason why there's a lot of uric acid in the blood could be a couple different reasons. One, and I think it's a very common one that's pretty easy to remember, is gout. Another one is tumor lysis syndrome. Another one is diabetes. And another one is foods that are very rich in purines. So what are these reasons again? Just to recap it, it could be gout. It could also be tumor lysis syndrome. The other one is it could be diabetes, and it could be a diet that's rich in purine rich foods, so purine-rich foods. And I don't even know why someone would even eat some of these. This is like shellfish and anchovies and organ meat and stuff like that. But if you have a purine-rich diet, that would also potentially increase the uric acid within the blood. If you increase the uric acid, which is in the bloodstream, what can that do? That could filter across the glomerulus into the kidney tubules. If they filter into the kidney tubules, you have a lot of uric acid potentially within the urine. If you have a lot of uric acid within the urine and the pH of the urine is also very acidic, guess what you end up forming, my friends? You end up forming a lot of uric acid stones. And again, the reason why you form these uric acid stones is because you have a lot of uric acid within inside of the urine under acidic pHs. All right, that's pretty straightforward, right? So acidic pHs, lots of uric acid. This is uric acid stones. High pHs, lots of calcium, is going to be calcium phosphate stones. High pHs and lots of particular bacteria that's causing this, struvite stones. And again, not a pH dependent state, but very little citrate, high amounts of calcium, high amounts of oxalate, calcium oxalate stones. The last one here, which is the least common one because it's usually genetic, is again a repeat here, less solvent, less stone inhibitors, and high amounts of solutes. Man, this is a very intense thing here, right? So solvent, so we have dehydration. This is definitely a stimulator. Less stone inhibitors. And it makes our life easy to remember that this is under what type of urine pH? This is under a urine pH that is very acidic. Acidic, 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 acidic. All right? And then this one is lots of solutes. And this is particularly lots of cysteine that ends up within the actual urine. So less solvent under dehydration conditions can cause solute formation, precipitation, stone formation. Lots of less stone inhibitors can stimulate solute precipitation and stone formation, and that's due to what type of urine pH again? This is a acidic urine pH. So a decrease in the urine pH, and we'll talk about the reasons for that in a little bit. And the last one here is because you have a lot of cysteine, and if you have lots of solutes, that also can stimulate stone formation, and again, you're gonna have lots of cysteine. We'll talk about their mechanisms for that. But real quick, it's the same concept. Urine pH, why is it low? It could really be any of the same things we talked about here. So it could be in a patient who has like a type 2 RTA, or it could be under a situation like chronic diarrhea. Who knows? Some type of situation where the urine is acidic. If the urine is acidic, what do we have a lot of in the actual urine? There are lots of protons in the urine. If you have lots of protons into the urine, what is that going to do? It's going to cause the urine to become more acidic. And if the protons in the urine are there and it makes the urine very acidic, it's going to increase the formation of cysteine stones. Okay, that is the situation here. We're going to increase the formation of cysteine stones. But in order for us to make cysteine stones, what do we need in the urine under this acidic condition? We need lots of cysteine. So what in the heck is the reason why we would have a lot of cysteine? Well, cysteine is an amino acid. So normally what happens is amino acids are filtered across the glomerulus, and generally they should be reabsorbed. So they should be filtered, and most of them should be reabsorbed back into the blood. If for some reason you have a genetic condition, so there is a genetic condition, disease that causes a decrease in amino acid reabsorption, you're going to lose all that cysteine into the urine. And if you lose a lot of cysteine into the urine, what do you think is going to happen? If under acidic particular circumstances, you're going to have a lot of this cysteine available within the urine. If it's there and under acidic conditions, it's going to be able to induce this cysteine stone formation. Okay? So it's some type of genetic condition. The big thing to look out for here on the exams is this is in usually some type of child. A child who's forming kidney stones. Shouldn't be a common one that you'd see in all these other ones, but this is definitely one that you would see in a young child. All right, we talked about all the different types of stone formation, thank goodness, right? And now what we got to do is we got to take into consideration, I have a patient who comes in, I think they have a stone. How do I find the stone? How do I emergently treat these stone formations? And then again, what are some long-term treatment processes? All right, my friends, so now we go into the next part here, which is how do we diagnose nephrolithiasis and how do we treat nephrolithiasis? So the first things first is whenever you have a patient who comes in and they present with that classic features of nephrolithiasis, they have that flank pain, maybe some CVA tenderness, it's radiating down to the groin area, and because of that ureteral spasm, they have some kind of renal colic where these intermittent bursts of large amounts of pain, they got some nausea, some vomiting. Maybe if the actual stone is stuck at the UVJ area, they could have some of the urinary tract kind of symptoms. But oftentimes, it's a patient who presents with that flank pain, that renal colic, the nausea, the vomiting, sometimes some possible visible hematuria, but usually it's microscopic. Those are things to start thinking about as a stone. Now, what I really want you to think about really quickly is whenever you have a patient who you think has this nephrolithiasis, you have to look for the acute kidney injury and the pyelonephritis, because those are the ones that are very emergent, and we don't want to delay a lot of time to looking for some particular things because we have to get on this as soon as possible. Okay, so look for the patient who has an acute kidney injury, some pyelonephritis, and again, the last potential thing is that uncontrollable refractory pain and nausea and vomiting that's not responding to medical therapy. If they have any of these, right, and how do we determine that? Well, again, look at their baseline creatinine, look at their baseline BUN, look at their urine output if you have like a Foley, and say, is there an acute rise in their creatinine, right, greater than 0.3 milligrams per DL within a 48-hour period, or is it more than 50% of their baseline within a 48-hour period? Those are big things to look for because that could tell you they have an AKI due to this stone. What if they have features of pyelonephritis? So they have that pain, but now on top of that, they have very high fevers. You get a CBC and it shows leukocytosis. These are other concerning findings of pyelonephritis. If you see any of these, you need to decompress them immediately because they're at high risk of deterioration going into fulminant renal failure or going into urosepsis, and that has very high mortality rates. So what we want to do is if there's a stone that's there, we just have to get urine kind of flowing because this is obstructing urine flow, causing urinary stasis or backflow pressures that are causing decreases in filtration of urine. So we have to get urine flowing somewhere. So one way that we would emergently decompress these patients is we can do what's called a ureteral stent. So you put in a stent and this helps to be able to reestablish the urine flow so we can get some of that urine out and prevent urinary stasis and causing infections and help to improve urine flow so we can reduce their acute kidney injury. If they're not amendable to a ureteral stent, sometimes under certain circumstances, it's easier to take like a tube, a catheter, and poke it through their back into their kidneys and drain some of the urine another route. And this is called a percutaneous nephrostomy tube. Okay, and these are generally temporary. One big thing that I have to tell you though, is when you put in a fresh piece of hardware, whether it be a catheter or a stent, you better make sure that you have cleared the patient's infection because you don't want to go infecting that particular hardware. And so sometimes if they do have features of pyelonephritis, you should really start them on antibiotics prior to decompressing them. All right, so really get them started on some antibiotics, get the infection cleared, and then go and emergently decompress them, okay? Now, if the patient has a normal BUN and creatinine, all right, in other words, they don't have an acute kidney injury, they have a normal white blood cell count, they're afebrile, they don't look like they have that pyelonephritis, then we're not at these true emergent situations where we have to decompress the patient. So then we can say, okay, I don't have to work to get them antibiotics and get them to the actual surgical suite to do a perc or to do a ureteral stent. So I have some time. What would I do? Well, the first thing is you need to treat that pain. That pain is like, it's crazy. And again, so one of the first things to do is to have pain control. And so you start off with pain control. You can do things like NSAIDs. You can do things like opioids. Generally, opioids would be very nice for the patient because it's extremely painful. The other one is because of the pain, they are having a lot of vomiting and nausea and losing fluid. You don't want that, especially if they're at risk for sepsis or at risk for acute kidney injury. So antiemetics may also be potentially beneficial for these patient populations. And the last thing here is it's been shown to potentially help to expel the some of the actual stone as well as reduce the spasm, is we can give another drug, and it's called an alpha-1 receptor type of blocker. And this is called tamsulosin. Tamsulosin. And this is nice. It's actually been shown to help to be able to relax some of the spasms and help to be able to kind of move the stone along. It may actually kind of a little bit of ureteral dilation. So these are the things that you're going to try at base, okay? Get some pain control, get some antiemetics, maybe even give these patients some IV fluids if they need to, and try to see if we can move that stone along. If the stone is less than 10 millimeters, oftentimes if the stone is less than 10 millimeters, medical therapy alone will be good enough, and you don't have to go and do any kind of surgical procedure. You can observe it, and generally it will pass spontaneously. Okay? It'll pass spontaneously. But if the stone is greater than 10 millimeters, or if they've become refractory to some of the medical therapy, then you may need to go the route of saying, okay, I need to do a surgical intervention. So if it's refractory to observation, refractory to medical therapy and observation, then you may need to go and do a surgical intervention, potentially. Or if it's greater than or equal to 10 millimeters in that size, you may need to go and do a surgical intervention. So that begs the question, what is the type of surgical interventions that we would have to employ for patients who have greater than or equal to 10 millimeter stones? Well, the first one that I want you guys to remember here is, we call this a PCNL, okay? So a PCNL stands for a percutaneous nephrolithotomy. So we call this a PCNL. This is an interesting procedure, and generally when we would do this is under two circumstances. We would usually kind of put like a scope, and we would run it through their back into the area of the kidney, and we would try to suck these stones out. And it's because there's just no way we're ever going to be able to get these stones to pass if we bust them up into pieces. And so we do this under two circumstances. One is if the stone is greater than or equal to 20 millimeters. If that's a big stone. So if you got a greater than or equal to 20 millimeter stone, or you have a staghorn. If you have a staghorn calculi, there's not a dang chance this thing is going to move. Okay, so under these two particular scenarios, you would have to do a PCNL. If this thing is between 10 to 20 millimeters, all right, so it's approximately 10 to 20 millimeters. It's definitely less than 20 millimeters. There's no staghorn, and just to be consistent with the color, because I like that there, the staghorn. If it's 10 to 20 millimeters and it's not in the kidney, so it's like mid-distal ureter, okay? So it's 10 to 20 millimeters and it's mid-distal ureter. These are generally amendable to two types. One is what's called extracorporeal shock wave lithotripsy. You take this probe, put it over their back, and hit a lot of ultrasound waves and bust the actual thing up into pieces. And eventually, as you bust it up into pieces, it'll be easier for them to pass. All right, this next procedure is more preferable. It gives a higher stone-free rate, and it's called a ureteroscopy with a little bit of lithotripsy that you'll actually apply to this one. And it's actually a lot more desired. And the reason why is you take this scope, you run it up through the ureter, and then there's this little kind of like ultrasound waves that you can shoot at this thing, bust this actual thing up into pieces, and as you bust it up into pieces, it's easier for it to be able to pass through. Now, again, it's important to remember that this one is going to be much more preferred because of a higher stone-free rate as compared to the extracorporeal shock wave. The other thing is that this one also depends upon the patient's body habitus. If you get a big patient, it's going to be harder for those waves to be able to get to the actual kidney stones. So that's why, again, this one is more preferred. So this is what we would do in a patient who has a kidney stone or a nephrolithiasis. And again, the basic questions that we're trying to ask is Is it emergent or is it non-emergent? And if it's emergent, we have these two therapies along with antibiotics if we're worried about sepsis. And if it's non-emergent, medically optimize them. If it's less than 10 millimeters, it should pass. If it doesn't and they're still uncontrollable, you can go to a non-emergent decompression. But if it's greater than 10 millimeters, it is unlikely that thing's gonna pass on its own. You're gonna have to do something about it. What we would do is, if it's greater than 20 or it's a staghorn, you gotta go with a scope into the kidney, PCNL. If it's in mid-distal ureter, it's very beautifully optimally positioned for ESWL or URS preferred, especially if it's 10 to 20 millimeters in size. All right, that's how we would kind of emergently treat this. You got to get on this right away. But the question is how do I know if it's nephrolithiasis, right? You're like, okay, Zach, well, you went right into the treatment emergently, which is great, but how do I know if it's a nephrolithiasis? All right, first thing that we want to do is we want to start looking for finding the stone. Get a way of finding the stone, and that's imaging. And there's a couple different ways that you can image. The preferable test, the gold standard is going to be the CT of the abdomen and the pelvis. This is going to be your gold standard. And the reason why is it's kind of straightforward here. This gives a great look at the abdomen and pelvis. It can find evidence of hydronephrosis. It can find a stone. It can calculate the size of the stone. It can look for associated complications, like maybe they have some perinephritic frat stranding, suggestive of pyelonephritis. Maybe they have a renal abscess. Or it can also tell you, is there something else going on in the abdomen that's causing this patient's pain? Right? That's another reason why it's really the best test. Another one that you could do, it's not desirable, but it would be an alternative in a certain select patient population, is you can do a renal ultrasound. And you can do this as an alternative to patients who are, you really want to minimize the risk of radiation. And generally this would be in particular patients who are like children, so very young children, or are pregnant, and you're just trying to minimize that radiation. But again, it would be suboptimal. It's not going to be the best preferred study for these patient populations. Again, you're going to want to get that CT of the abdomen pelvis. It's going to be the best. The other alternative study, which is never going to be the correct answer, I need you to remember this, it's never going to be the correct answer. It's called an intravenous pyelogram. This used to be a highly utilized study, but it's never going to be the correct answer. Never correct. The reason why is with the availability and the use and the ease and the success of CT abdomen and pelvis, this is no longer utilized anymore. All right? The next test here is going to be a kidney, ureter, bladder x-ray. Again, not really the best test, but what it can do on your exams is hint to you as the particular type of stone. And that's what they try to get with on the x-ray here. So with the KUB, what you're looking for is there a stone that's popping up? In other words, we use the term radioopaque. Is it radioopaque? Or is it radiolucent? In other words, I can't really see the stone. The reason why this is helpful is this can elucidate the specific type of stone, with 3 stones being relatively radioopaque and 2 stones not really being easy to see. The 2 big ones that you won't be able to see here is going to be your uric acid stone and the cysteine stones. You won't be able to see these due to their structure and the components that make them up. The ones that are radioopaque is going to be calcium, oxalate, and calcium phosphate. And the other one, and that's because of the calcium is very highly dense, so you'll be able to pick that up. And the other one is the struvite. And the great thing about the struvite here, and this is why they would likely present this on the actual exam, is you can see that crazy staghorn calculi, that big sucker on the KUB. So those are things that I really need you guys to be looking for, again, on your KUB of x-ray. But if a patient has, again, features of a stone, you got to find the stone and be treating it around the same time. The thing that you want to go to is this test. Now, we found the stone with the CT of the abdomen and pelvis. Maybe we got a KUB x-ray just before that to also rule out other weird reasons for abdominal pain or flank pain. Maybe we're trying to rule out they have a bowel obstruction or something like that. We get the KUB, we find a weird stone somewhere, we get the CT abdomen and pelvis, we definitively find the stone. We don't do the renal ultrasound, we don't do the IVP. The next thing is we want to be able to find the type of stone and then also guide our long-term therapy, which is pretty cool. So what we would do is we get a couple different tests. First, you get a urinalysis, all right? Then with the urinalysis, you want to add on the microscopy study to the urinalysis. And this is the only one that we don't often do right away. You do this more for a patient, like the 24-hour urinalysis, if they are constantly getting stones. If they're constant recurrent stone formers, you can consider a 24-hour urinalysis, but oftentimes these are the two tests. You won't really do this unless it's a long-term kind of thing that you want to watch out for because they have recurrent stone formation. But these are the two to start off with. Once you do this, you're going to get a bunch of information that can help you. First thing is look at the urine-specific gravity. And again, this is kind of a little bit extra, but I want you to think about it for treatment. If the urine-specific gravity is very high, that means that the patient is likely dehydrated in some way, shape, or form. What did I tell you was one of the particular factors behind a patient having stone formation? One was less solvent, dehydration. What would be a good treatment option for patients who are dehydrated, my friends? This would be giving them some type of fluid intake, really amping up that fluid intake. This could be in the form of IV fluids. This could be telling them to drink oral fluids a little bit more at home. The next one is you may be able to see a lot of red blood cells. What did I tell you was a finding, one of the reasons why you would have lots of red blood cells? And what's that called when you have a lot of red blood cells in the urine? This is called hematuria. Usually this is going to be microscopic. It's very rarely macroscopic. There's nothing that you're really going to be doing to treat this. This is just usually a complication from the ureteral irritation, the mucosa damage. And if you treat and get rid of the stone, you should actually start seeing some residual loss of that hematuria. The next one here is if I see a lot of white blood cells, some positive leukocyte esterase, some positive nitrites, and some positive bacteria. This can be somewhat complicating. Now, it could tell me I have a pyelonephritis. But sometimes if you think about it, the stone is kind of blocking a lot of these things from getting past, getting into the actual bladder. But it could tell me there's a pyelonephritis, but what I want you to be thinking about is using this to tell you the type of stone. And so what I would want to think about is what is the one type of stone that forms because of lots of bacteria? You guys remember? The struvite stones. So I want to think about the struvite stones. And again, I'd be able to get some of that information off because if my KUB showed a staghorn or my CT abdomen pelvis showed me a staghorn calculi, that would be one particular reason. But if my urine also shows evidence of a lot of bacteria potentially being there and inflammation, that also suggests the struvite stones. What would be the best thing for a struvite stone? Well, the best thing for a struvite stone is going to be giving antibiotics. Oftentimes you should do a urine culture to find the specific type of bacteria, but you're oftentimes going to be doing antibiotics. Okay, so you're going to be doing some type of urine culture and then following it up with antibiotics. Now the antibiotics generally are supposed to guide your specific antibiotic therapy, and so that's why you really want to be able to obtain those. So again, treatment for this would be obtain some urine culture and then maybe start some antibiotics. All right, the other thing that we can obtain from the actual urinalysis is the urine pH. Now, what I want you to think of is what if the urine pH is low? What were the two types of stones that forms at low in urine pH? That was the uric acid stones. And what was the other one? Cystine stones. Do you guys remember, just as a quick little tip, what were the reasons why? It could be because of a type 2 RTA or because of diarrhea. With these, if you have uric acid stones or cystine stones that are forming at these very low pHs, what do you think would be a good thing that you could do to the urine to make the pH a little higher? You could alkalinize it. And so what we do is we do what's called potassium citrate. And basically this is going to act as an alkaline agent and make the urine pH higher. If you make the urine pH higher, what do you do to the stone inhibition? You actually increase the stone inhibition and inhibit stone formation. If we have a high pH, what were the two types of stones that you want to remember for this one? This was the calcium phosphate, and this was the struvite stones. So that would be another thing to add on here. If I have a high urine pH, features of infection that's seen within the urinalysis, and a KUB or a CT that shows a struvite stone or a staghorn, that would be another potential feature. What could I do for these? Well, if this is under alkaline urine, maybe I should acidify the urine. And sometimes this is very simple. You can do this with a lot of different things. Sometimes it's as simple as like cranberry juice that could help to be able to acidify the urine. But this is the big one, alkalinizing it. All right. The last thing that I want you guys to do is look at the microscopy. So once we've obtained, this is all going to be pretty much off the urinalysis, and then we add on the microscopy to the study. What the microscopy will do is it's going to show you all these different types of crystals that you want to be able to pick up. So if I go to the urine microscopy, I'll be able to elucidate, for the most part, which type of stone it is, which is very helpful. So if I see a dumbbell shape, this is what I want you to think about, which looks a little bit like this, then you want to think about what's called a calcium oxalate stone. If you see a rhomboid or needle-shaped stone, which looks like this, then you want to be able to think about a uric acid stone. If you see a wedge-shaped stone, which looks like this, then you want to be able to think about a calcium phosphate stone. And if you see a coffin lid-shaped stone, which looks like this, then you want to think about that struvite stone. And lastly, if you see this hexagonal shaped stone, which looks like this, then you want to be able to think about this cystine stone. So these are some ways that you can utilize this, but you can use all these different things that we just talked about to help you to come up with the diagnosis of the type of stone. The gold standard will be a 24-hour urinalysis that I talked about, but again, you don't often do that unless they're recurrent stone formers, but that would be the best. Now, to guide the treatment, the long-term management to prevent these stones, you have to go back to the causes. So this is where you guys got to go back to your causes and think, all right, what were the reasons for the calcium oxalate stones? What was the reason for my uric acid stones? What was the reason for my calcium phosphate stones, my struvite stones, and my cystine stones? All right, so for calcium oxalate, there were two particular things. We already talked about giving them fluid and then fixing up the urine pH. But now we got to go up to the other things, which are the solutes. So we got to treat the solute problem in each one of these. And that's really where the issue arises. For calcium oxalate, what was the particular problem? They have lots of calcium. So what do you want to do? You want to reduce their calcium and reduce their oxalate within the urine. So how do you reduce the calcium in the urine? And how do you reduce the oxalate in the urine? Well, it's very odd, and it may even sound a little bit challenging and weird, especially for this one. But for the low calcium, the biggest thing is treating the underlying disorder. Do they have hyperparathyroidism? Do they have hypercalcemia malignancy? You got to treat those things. But the things that are really easy to treat is basically, if you guys remember, we were inhibiting calcium reabsorption. What if I stimulate calcium reabsorption, so less calcium is in the urine? Do you guys remember what were those things? It was the high sodium diet, high protein diet, and loop diuretics. What if I decrease the sodium in the diet, I decrease the protein in the diet, and I switch up the diuretic? So if I have less sodium in the diet, that's going to help to increase calcium absorption. If I have less protein within the diet, that's going to help to increase calcium absorption and decrease the calcium in the urine. And lastly, if I use what's called a thiazide diuretic, that actually increases calcium reabsorption in the distal tubule and has less of the calcium within the urine. These are ways that I can reduce calcium in the urine and reduce calcium oxalate stone formation. The last one here is, what about this oxalate? I got to get rid of this. Well, it's simple. One is reduce the oxalate consumption, right? Any kind of thing that has a lot of oxalate, you know what the biggest thing is, and everybody always talks about, it's really tea. So iced tea is really rich in oxalate. So you want to reduce oxalate foods. And I think the big one to remember here is that particularly is the iced teas. The next thing, and here's what's really, really weird, because it seems contradictory, but you have to go back to that path of is, do not restrict calcium. You don't want to restrict the calcium. And do you guys remember why? If you restrict calcium within their diet, what's going to happen to the amount of free oxalate in their GIT? It's going to be increased, and it can absorb. get into the kidney tubules, and then form calcium oxalate stones. So make sure that you have them take an optimal amount of calcium, just do not restrict the calcium, even though it seems paradoxical to the formation of calcium oxalate stones. All right? Next thing is uric acid. How do we reduce the uric acid? Well, there's really one particular way. One is you have to think about why you're forming it. So is it because of gout? Treat the gout. Is it because of tumor lysis syndrome? You can actually give a specific thing for that. Or in patients who have, in patients who have gout, tumor lysis syndrome, maybe even diabetes, what you can do is you can actually give them a drug that basically inhibits uric acid formation. You know what this drug is called? It's called allopurinol. So allopurinol basically inhibits purines from getting converted into uric acid. And you should also reduce their purine-rich diet, right? That's another, stop eating shellfish and anchovies and organ meat. The next thing here is the calcium phosphate. We want to reduce the calcium. So it's the exact same thing that I talked about before with the calcium oxalate. The problem with this one is you really want to reduce the calcium in the urine. And how do you do that again? I already told you that it's reducing the sodium in the diet. I already told you that it was reducing the protein within the diet. And give thiazide diuretics because that helps to induce calcium reabsorption in the distal tubule. All of these things will help to be able to increase the calcium reabsorption and reduce the amount of calcium that's present within the urine. What about struvite stones? Struvite stones is pretty simple. Don't even make it complicated. It's antibiotics. Done. Cystine stones. You want to have something that binds with the cysteine and make sure that they don't precipitate. And so one of the drugs that we can actually utilize in these patients is what's called tiopronin. And that basically is going to prevent the cysteine amino acids from clumping together and making the cystine stones. And again, at the same time you're treating the underlying problem of the solute, you have to give them fluid because of the decreased solvent and fix their urinary pH. Alkalinize the ones that have what? The low pH, and then acidify the ones that have the high pH. All right, my friends, in this video we talk about nephrolithiasis. I hope it made sense. I hope that you guys enjoyed it, and as always, until next time.